So good afternoon, everyone. Thank you for joining here. Hopefully you're able to hear me okay. I'm David Reed, the Deputy Director of Child Welfare Services for the Indiana Department of Child Services. And it's a pleasure to be here this afternoon to talk with you all about a new initiative that has launched within the department statewide called Indiana Family Preservation Services. And we'll talk all about these services here this afternoon. We've got kind of a lot of material to get through, and I want to try and have some time for Q&A at the end. So I'm going to just dive right in the hopes that we can get through all of the material and have some Q&A time. So again, it's called Indiana Family Preservation Services. And I want to start by talking about why DCS embarked on this initiative to try to preserve more families. Why was this such an important goal for the department? And then everything that we do really should be with a foundation in research. And I'm kind of a child welfare research nerd myself, and I'm quite familiar with a lot of the research of what trauma exposure in childhood predicts for kids. And I suspect many people out there listening to me talk right now are familiar with this particular study. It's the most well-known research on childhood trauma exposure that we have, and it's called the ACE study, or Adverse Childhood Experiences Study. And this was, truly landmark child welfare research that started back in the mid-90s when I was just finishing graduate school and starting my career in child welfare. And it was conducted back then by a health insurance company, Kaiser Permanente. And what they found in their research is that adverse childhood experiences or childhood traumas have long-term effects, and they're predictive of certain outcomes for kids. They looked at some specific childhood trauma exposures in their research. They looked at kids who had experienced physical abuse, sexual abuse, neglect, serious illness or injury, kids who had witnessed domestic violence, kids who witnessed other types of violence, separation from caregivers, and loss and grief. And to clarify, they asked adults these questions about exposure to these traumas when those adults were kids. So they asked adult members of Kaiser Permanente, the health insurance company at the time. They asked their members about exposure to these traumas when they were kids. And these last two are bolded because I think it's really important for child welfare to pay attention to those last two that again were studied in the research: the separation from caregivers and loss and grief. Those are the outcomes of DCS involvement when we choose to remove children from their families. We create that separation from caregivers, and we create loss and grief for kids. And in many cases, we became involved with that child because of one of these first three on this list. So physical abuse, sexual abuse, or neglect. So we might meet a child who has had one ACE, and each one of these traumas is an ACE, not like every time physical abuse occurred, but having experienced physical abuse in childhood is an ACE. So we may have become involved with the child because they have an ACE. But if we choose to remove that child because of that, we have potentially tripled their ACE score because we've added that separation from caregivers and that loss and grief. And that's really noteworthy because what the research tells us is that exposure to childhood trauma and having high ACE scores are predictive of certain outcomes in adulthood. What childhood trauma exposure predicts for people as they enter adulthood are things like addiction issues, unwanted or early pregnancy, poor educational outcomes, employment problems, mood problems, marital problems, legal problems, And ultimately, what they found in their research, and again, they were a health insurance company. So they were trying to figure out what was impacting their members' health. And what they found was that folks who had high ACE scores died younger than those who did not have that childhood trauma exposure. So again, go back to the slide here, this list of traumas, each one of these is an ACE, and having a high ACE score is predictive of outcome. With a lot of the birth parents whose kids are now involved in our foster care system, they present with these kinds of issues. We commonly see adults who have addiction issues whose kids are now involved in the DCS system. Or we have, so people don't recognize this, but about half of the kids in the DCS system are under age 5, lots of itty bitty kids. And it's not uncommon for those very young children to have grandparents who are in their mid 30s. And that speaks to that early unwanted pregnancy, poor educational outcomes. It's rare that we have adults whose kids are in our system who have advanced degrees, college degrees, master's degrees. What we see far more commonly are folks who maybe didn't finish high school or get a GED. We see folks who have employment problems, who haven't been able to maintain gainful employment. And oftentimes that's because they have mood problems that prevent them from being able to maintain not only employment, but also relationships. And when you think about marital problems being next on this list, that is what they found in this research, predicted by childhood trauma exposure. Also, many of our birth parents whose kids are involved in our system have lots of legal challenges as well. We see some pretty long rap sheets with some of the birth parents with whom we work. And then lastly, a lot of our birth parents, they're not exactly the picture of health. There's high rates of smoking, obesity, diabetes, heart disease. These are the kind of things that will shorten your life. And all of these things, each of these things, that again looks like a lot of our birth parents were predicted from childhood trauma exposure. So this is really important research for anyone involved in child welfare to understand and to recognize that today's kids who have high ACE scores are likely to look like this tomorrow. And the people who look like this today were once children themselves. And what kind of childhood trauma exposure did they have? It's just important for us to recognize what childhood trauma exposure predicts for people. And then also with the ACE study, quickly, it's a dose response. Anyone out there who does research understands what that means. So again, the higher your ACE score, the more likely you are to have outcomes that look like that previous slide. And again, our interventions, especially when we choose to remove, increase ACE scores for kids. We create that separation from caregiver, and we create that grief and loss. And there's other research as well about what separating children from their caregivers, what that does to them. We know through volumes of research about the impact of disrupted attachment. Attachment begins at birth, actually even before birth. In utero, babies are bonding and attaching to their mothers. And when it is disrupted, and again, this is research-based, we know that the child is harmed in numerous ways. They're impacted emotionally, socially, physically, and intellectually from that disrupted attachment. We also know anyone who's been working in child welfare for very long knows this to be true, just from talking with kids, that abused kids are as attached to their caregivers as non-abused children. I've been working in child welfare again since the mid-90s. A big portion of that was actually spent with older youth who were exiting foster care as adults. So they were aging out of our system. And almost every time, if they aged out without having achieved permanency through adoption or reunification, where do they go? Back home. They go to their mom or to their dad, which speaks to the attachment. We know they had experienced abuse and neglect, probably at the hands of that caregiver, but yet they still returned to that caregiver the first chance they got when they became adults and exited our system. So abused kids are as attached to their caregivers as non-abused kids. And kids want to be with that primary caregiver. They just want to be safe there. And that's where our interventions as a department can help maintain those relationships, but also allow kids to be safe with those primary caregivers. And there's still more research. And again, there's volumes and volumes of research on the impact of removing kids from their caregivers. We understand that through research, kids who have suffered traumatic separations from their parents, and make no mistake, taking a child from their family and placing that child into foster care is indeed a traumatic separation. We know that kids who've experienced that oftentimes display low self-esteem, a general distrust of others. They oftentimes have mood disorders. They oftentimes are not as emotionally mature as their peers, and they oftentimes lack adequate social skills. And if you've worked with kids in foster care, you know this slide to be true as well. Again, I worked in foster care for 25 years now, and it's very common that we see kids in foster care present like what is on this slide here. And also, kids, when they come into foster care, in many cases, regress behaviorally. I've commonly worked with kids over the course of my career, and I was a therapist for a long, long time with kids in foster care, kids whose behavior and functioning regressed when they entered foster care. They weren't wetting the bed when they were home, for example, but when they come into foster care, we see a return of that behavior. We also see kids who experience cognitive and other intellectual delays, who have experienced traumatic separations. And then still more research. Study after study shows that kids who go into foster care have worse outcomes than kids who are able to be maintained at home with their families. There are some very well-known, well-designed studies, longitudinal studies done from MIT, where they've got lots of very smart people, obviously, who evaluated the impact of kids who were comparatively maltreated, the same level of abuse or neglect, one group able to remain with their caregivers, and one group experience foster care. And what they found was the kids who experienced foster care were less likely to hold a job that lasted 3 years or longer, more likely to become pregnant as teenagers, more likely to be involved in the juvenile justice system, and more likely to be arrested as young adults. And think back to the ACE study. And these were all outcomes that were on that slide of what childhood trauma predicts. So it's not surprising then, if you increase trauma for kids by placing them into foster care, they are more likely to have outcomes like this as they grow up. That just validates what the ACE study tells us. And the other thing I think is important to note about the ACE study, a clear takeaway if you read that research, is that childhood trauma exposure is common. Lots and lots of people are walking around with ACE scores, high ACE scores, and they're quite successful. They go on to be successful adults. How many of those people experience foster care, however? I think that's a question we have to be asking ourselves, because again, we know childhood trauma exposure is not uncommon at all. And in our quest, DCS's quest to prevent harm that we can see, so the ugly headline, the fatality or near fatality at the hands of abuse or neglect, awful headlines that we've seen, and we will try very hard to prevent. In our quest to prevent that harm that we can very clearly see, we have to recognize that we are causing harm to that child that we can't see if we're choosing to remove. We have to remove some kids. I want to be very clear about that. We're never going to get to a point where every child's able to be safely maintained with their families. But can we try to prevent more kids from entering foster care? Because we have all this research that tells us what entering foster care predicts for kids. So with that being the case, we should ask ourselves, how has Indiana, our state, been doing with keeping families together let's look around and figure that out. So when I started here at DCS, that was back in September of 2017. And really at that time, there were record numbers of open DCS cases and kids in foster care. This place was kind of a circus at the time because there was a lot going on. The previous director resigned soon after I started. There was a lot of attention being given to the department. A new director came in, and Governor Holcomb asked for a complete assessment of the department and its functioning. He brought in this national, well-known child welfare research group called the Child Welfare Policy and Practice Group to do a complete assessment of the department. And that assessment is still available on our website. It's an interesting reading. And one of the key findings in their review of the department was that in a 12-year time period, so from September 30th, 2005 through September 30th, 2017. And again, I started here September 2017. During that 12-year time period, what they found in their review of the department was that we had an 89.4% increase of kids entering foster care during that time period. And that we had on 9/30/2017, so September 30th, 2017, we had 20,394 kids in out-of-home care. And our population as a state is 6.6 million. So a lot of kids came into care during that time period. And I think people, if they were paying attention to that huge increase, would say, well, that was the opioid crisis that led to that dramatic increase in kids. But the CWG assessment looked at other states as well, including the states that we share borders with. So let's review what happened in those other states during that exact same 12-year time period. Let's start by looking to our west in Illinois. During the same 12 years, 9/30/2005 through 9/30/2017, they had a reduction of 13.1% of kids in out-of-home care, kids in foster care. And that reduction was 13.1%. And on September 30th, 2017, they had 14,255 kids in foster care. They had 6,000 fewer kids in foster care, but their population is almost twice what ours is. 6,000 fewer kids with twice as many people in their state. Look to our south in Kentucky. Yes, they had an increase, but a comparatively modest one. Their increase was 17.3%. And on September 30th, 2017, they had 8,000 kids in foster care. We had over 20,000 kids in foster care. Now, granted, Kentucky has fewer people than Indiana, but not half as many people, not a third as many people as what Indiana has. How about to our north? During the same 12-year time period, Michigan had a decline of 40%. We nearly doubled, and Michigan went down 40%. And on September 30th, 2017, they had just under 12,000 kids in care, 8,000 fewer kids in foster care than us, yet they have about 4 million more people than we do. And then lastly, look to our east, to Ohio. During the same 12 years, they went down 10%. We doubled, they declined. Their number of kids in foster care was 14,891, and they have, again, about twice our population, 7,000 fewer kids with twice as many people living in their state. It was clear that Indiana could do better with keeping families together. And that's kind of why I came to DCS in the first place, was recognizing the crisis that our state was in related to the number of kids entering care. So all this is happening right around middle of 2018 when the findings came out, and we started really thinking through how can we help support families better so fewer kids have to enter foster care. And you fast forward to the legislative session that happened that following spring, so early 2019, there became a new DCS mandate that said, this is in the budget bill back in 2019, so House Enrolled Act 1001 of 2019, There was a mandate in that budget bill that DCS shall reimburse providers for family reunification services using a per diem model. Now, prior to this passing, most of what DCS provided for family services were reimbursed with a fee-for-service model. We pay providers by the hour for the work that they did with families. This was going to force us to change our reimbursement structure to go away from fee-for-service and towards per diem. And we've been talking internally about per diem and its benefits prior to this passing. So this was going to be a big change, but as we thought through per diem, we could see some benefits to shifting how we reimburse providers for their work. I'm going to review some of those benefits with you now. So, first of all, we have what's called the DCS Practice Model. And the DCS Practice Model behind me there on the wall, it's how we do what we do. It's how we interact with kids and families. And it calls for us to team our cases, to get together and talk with families and with providers and with CASAs and guardian ad litems, other important people involved with the family on a regular basis and talk about how the family is doing. But with fee for service, the way we had been reimbursing for services, it was very common for one family to have 3 or 4 or 5 different agencies all involved with the same family at the same time. They were each kind of doing different types of interventions, kind of shotgunning services at families. That made it hard for us to follow our practice model of teaming our cases, getting everyone together to try to have a conversation about how the family is doing. Getting a team meeting together was a lot like herding cats back in the day, because we had to call 5 different agencies and figure out how we can get them all at the table with the family at the same time. Going to per diem wasn't going to allow us to continue to have 5 folks involved with the same family. We're going to have one agency doing comprehensive services with the goal of trying to preserve that family. Doing that would allow us to team our cases better. We'd be able to coordinate our cases better by having one provider to contact. Again, a provider doing comprehensive work with the family with a clear goal. Also, make no mistake that when we're involved with the family, they are in crisis. No one thinks clearly when they are in crisis. And if we throw 5 different agencies all doing kind of different things at a family who's already in crisis, we're going to add to their confusion. But by having one agency doing comprehensive work with the goal of supporting that family, keeping that family together, will reduce that confusion for families, as well as for our own staff, our own family case managers, who are the ones putting together the child and family team meetings and who are creating the referral for services. Having one referral to create reduces confusion for them as well. And there are still more benefits. Bottom line is with fee for service, all of our agencies have to generate enough billable time in order to function, in order to keep their doors open and their lights on and their staff employed. Billable time would drive how providers interacted with families. And with per diem, you aren't incentivized by billable hours. There's no incentive to overbill or spend too much time with the family. We want to provide the right intervention at the right intensity with the right family. And shifting to per diem allows the provider to not worry about billable time or revenue, but really focus on what's the best intervention for this specific family. Revenue goals really shouldn't dictate service intensity for families. The family's needs should be what dictate that service intensity, and going to per diem would allow us to focus on that. In addition, in the past, when we had 3 or 4 or 5 different providers involved with one family, we couldn't track outcomes at the provider level in any real meaningful way. If the family didn't get to a good outcome, who do we talk to about improving their services? And if they did get to a good outcome, to whom do we give the credit? Which of those 5 agencies was most responsible for helping that family get to that positive outcome. With one provider working with each family, we can much more clearly see the impact of provider interventions, specific provider interventions, how they impact families, which is helpful for us as the Department of Child Services, but also for our providers as well, who want to get better, who want to serve families better tomorrow than they're serving them today. But without having outcome data, it's really kind of hard to improve. This will allow us to improve. And there are still more benefits. In the past, providers had to worry about billable time. They had to worry about how to make sure what they were doing with families was going to result in them getting some revenue. They couldn't focus on helping families become self-sufficient and use their own community resources, because doing so wasn't going to be conducive to billable time. With per diem, if they want to do collateral kinds of contacts, if they want to send text messages to families, if they want to send emails with a list of resources for them to look at if they're trying to find employment or stable housing or need to apply for Medicaid or TANF, they can send that information through email or text. Everyone's got smartphones these days, and be able to have that family learn about those resources. Whereas in the past, if they did those exact same interventions, there'd be no billable time, because in the past, we only paid for face-to-face time with the family. Sending those texts or those emails or making those phone calls is a good use of time for many families, but they couldn't do it in the past because they would not get revenue for it. With this, they're getting daily rate reimbursement. They can send those texts, help that family better understand their community resources without worrying about how to make that work billable. And the other thing that we saw commonly across the state, and we were a fee-for-service primary state for probably the previous 12 years or so to when we launched this. And what we saw commonly with that is that families who needed the most help got the least. Because what would happen if the provider went to a home, knocked on the door, and the family wasn't there, or they just didn't want to see the provider that day, the provider didn't get any reimbursement. We only paid for face-to-face time with the family. If the family was hard to engage after 2 or 3 attempts of going to that home and going all the way out there and utilizing that time and getting no revenue for it, providers would stop trying, because they couldn't keep knocking on that door, because if they did, they were giving their time away for free and not getting any revenue back. But that family needs our help. We're involved for a reason. We need someone to keep knocking on that door, but providers couldn't do it, not and keep their doors open themselves. Whereas conversely, the families that were responding really well, the families that were always home, that's where providers were spending their time, because they knew there was revenue in going to that home. But that home, that family was doing the best. They didn't need all that time with the provider. The provider's time would have been much better spent not going back to that house for a 3rd or 4th time this week, but go to that other house again. I know they dodged you yesterday. Go back today. Go back tomorrow. Send a text. Get that family to engage. Continue to try. We're going to pay you now to continue to go out there. The same reimbursement as if you saw them that day. So please continue to go to the house. And the family that's doing well, you don't have to keep going there. That family is learning how to be self-sufficient and take care of their own family without DCS provider intervention being necessary. Shifting to per diem will allow both families, the one who's engaging and the one who is not, to get to good outcomes. But the most important benefit with this initiative is that we actually have a clear goal. We are trying to preserve more families. The research compels us to do that. All 20,000 kids who were in foster care on September 30th, 2017 in Indiana, they're all going to grow up. Healthy or not, they're going to be adults someday. And we need to recognize that continuing to remove kids, the numbers that we had been removing them, was not going to predict healthy adults in tomorrow's generation of adults here in our community. So we have to focus on this important goal of preserving more families. And if we do this right, unfortunately, there's evidence that we can prevent that trauma from happening to more kids and allow them to grow up healthier and in safer families. So what does this look like? So we have a brand new service standard that we launched statewide on June 1st, 2020, right in the middle of the early days of the pandemic. And these are home-based, face-to-face services, because it's critical. All of these case types, these services are being referred for every family where DCS has been called about an abuse or neglect allegation, and we investigated it and found that to be true, but we didn't choose to remove. So all of those cases where there's been a child that's been abused or neglected, what we didn't remove, are being referred for this service. We've always had these case types. We've always had case types where a child was abused or neglected. We investigated, found it to be true, but didn't remove. They're called in-home CHINs. CHIN stands for Child in Need of Services, or informal adjustment cases. And all those case types are being referred to this service starting June 1st, 2020. So last June. And these are family-centered services, again, with all those case types being referred. And we're not going to argue about rates with providers. In the past, DCS has tried to identify who are our hardest families, and we give providers more money to serve them, and who are our easiest families, and we give providers less money to serve them. And that led to very perverse arguments between the department and providers about just how challenging a family was. The provider would say, that's a really challenging family. They want to get a higher rate. We would say, no, they're not that hard. We want to pay a lower rate. No, it's a family. All of these case types have the exact same per diem rate all across the state. There's no leveling. There's no, the CANS instrument is a tool that we've used over the years, and it is an assessment tool. And we used that in the past to determine some rates for different parts of our services. We're not doing that with this. It's one rate statewide. And again, one provider agency per family doing comprehensive services with that family. We are very focused on safety with these services. Safety planning is critical because, again, all these cases have a child that has been the victim of abuse or neglect while in the care of the people they are still living with. So that being the case, we must be very focused on safety planning, and we are. The provider has to involve DCS and the family in creating their safety plans for each case. And again, they're home-based services that focus continually on assessing safety. And providers, if they encounter any safety concern at all, must call DCS and have an actual conversation. They can't just send an email or send a text. They need to pick up the phone and call the family case manager, failing them, the supervisor, failing them, the division manager, failing them, the local office director, all the way up to our hotline to make sure that we are aware in real time of any safety concerns happening with these cases. Providers must use evidence-based practices and concrete supports in the provision of these services. Evidence-based practices are practices that if you follow them to fidelity, if you do them as they are prescribed, we can expect good outcomes for families. There's evidence to say that if you do them correctly, the family will benefit. That's what evidence-based means. And we require providers who are doing these services to use an evidence-based model. But the provider, the expert, predicts what model they use with the family, not the family case manager, who's not a clinician, who doesn't understand the various evidence-based models that might make sense for that family. The professionals, the experts, the providers who earn their contract decides what models they use. And this helps prepare us for our eventual implementation of the Family First Prevention Services Act, which is federal legislation that Indiana will implement this fall in September, which also requires evidence-based practices with the goal of preserving more families. This lines up very well with what the federal government is wanting states to do all across the country to improve outcomes for kids and child welfare. But importantly, beyond just evidence-based practices, providers must use their per diem reimbursement to meet concrete needs of families. So things like the gas got shut off and it's the middle of the winter. We don't want to have to remove kids because it's cold outside. I just went through all that research about what removing kids predicts for them. And if paying a $200 gas bill will prevent trauma for a child that predicts a worse outcome for that child, that's $200 very well spent. So we're going to ask our providers who are delivering these services to use their per diem reimbursement to pay that gas bill. Now, providers don't want to do that. They don't want to use their reimbursement to pay the gas bill. What we're really trying to do is get providers to teach families about community resources, teach them about the trustee's office, the faith community, help them apply for TANF, help them budget their income. The providers that do the best job of connecting families to resources will be the ones that write the fewest checks to gas companies, but it'll be families who win because families will know about those resources so that when we close our case, if the dad loses his job again for whatever reason, they'll know about the trustee's office or the faith community or how to apply for TANF. They won't have to come back into DCS care in order to get those really important needs met. Again, if I have evidence-based models, they have to be trauma-informed care that is strengths-based and focused on supporting families, really supporting families, not judging families. These are not hoops for families to jump through. We are trying to support that family in a way that allows kids to stay with that caregiver, which we again know in research predicts better features for both the child and the parents alike. Again, they're individualized services, so it's the right service for the right family at the right time, at the right intensity. And we're measuring outcomes. We're able to see across our state who are providers that are doing the best job of keeping families safely together. And again, with billable hours not being part of the formula anymore, providers can really focus on what does the family need and give them that, rather than worrying about how do I get enough billable time to maintain my employment here. We can focus on outcomes and not on hours. So that's a very high level overview of the service. And like I mentioned, we are reviewing outcomes about how we are doing with this service that launched statewide June 1st, 2020. Since that time, we've had well over 2,000 families that have received this service all across the state. That includes over 4,000 kids, closer to about 6,000 kids now that have been enrolled in this service. We know from evaluating our outcomes that less than 3% of these kids have had another incident of abuse or neglect that was substantiated. Now, we are also comparing how we were doing with this service versus the old way of serving families. With the old way of serving families, the incident of repeat maltreatment for this case type was 68.5%. What we are seeing with this new way of serving families is less than 3% who have experienced another incident of abuse or neglect. And even better, less than 2% have gone on to experience a removal. And again, the rates of removal in the past was in the high 60s. We're at 2%. Now, this will change. And full disclosure, that high 60s percentage was within 2 years of DCS involvement. And we are evaluating this service with the 2-year lens as well. And we'll see how it compares. But these are very encouraging early returns on how the service is helping families. We have a very formal evaluation. You can read all about it on the DCS website. The evaluation launched January 1st of this year. We'll be submitting the evaluation to the federal government, the Federal Children's Bureau, in the hope that we can use some Title IV federal funding to support these services across the state. And there's also an entire web page devoted to this service model on the DCS website, and there's the link to that. We have 5 minutes left. I probably talked a little too long, but I was hoping if you have any questions, you can maybe put them into the chat, and I could try to respond to any questions that folks might have. Question looks like, is the results, are the effects of separation still true if they are adopted when young? That is such a great question, and I get asked it a lot. And I look at, so a lot of what we do involve kind of 3 groups. We have our families that we're trying to preserve. We have our kids that we're trying to get adopted because we weren't able to preserve the family. And then lastly, we have our kids who age out of our system. And we've done so much for each of those 3 groups. We have really improved what we can do for those kids who age out of our system. But sadly, in spite of all of our efforts, it's clear those kids struggle the most as they enter their adult lives. We have built in so many supports, but that's still clearly a 3rd best outcome for DCS involved youth exiting our care. The next group is adopted kids. And sadly, we see those kids struggle too. I've worked in adoption for a long, long time. And yes, having family-based permanency is far better than aging out. We know it. But we know many of our kids who were adopted, even kids who were adopted very young, struggle as they enter their adolescence and enter their adult lives. And again, think back to the research. Attachment and bonding begins in utero. And so even after birth, at newborn, there is a separation. There is a severing of that attachment that occurs. It's still far better than entering foster care and aging out of our system. That is clear in the research. If you can keep a family safely together, that's the best outcome for kids. Or reunify them if you had to remove. Are you now using one provider per family? If so, who is that provider? Great question. So it's actually 95 providers who earn contracts across our state. We did a competitive RFP process last winter. And again, contract started June 1st of 2020. So the RFP closed in February of 2020. We had 125 or so proposals. 95 of those went on to earn contracts. There are at least 7 providers in every region in our state, but it's one of those providers per family that's delivering these services. So some providers have more expertise, for example, in things like substance use disorder. So we want the referral for families that have that present to go to that provider, but it's just that provider doing all the family needs to keep that family together, to again measure outcomes at the provider level. But there are 95 providers across the state that have these, actually 96 now, because we added another community mental health center outside of the RFP. So one provider per family, but we do have contracts in place with multiple providers doing this service. As early childhood providers, how can we help the children who have been separated and adopted or in foster care? We have both adopted and foster care children in our program. So ensure that they have safety, ensure that they have safe stability in which to heal if they had to be removed due to abuse or neglect. Research is really clear on that as well, that kids heal in the context of relationships. And so make sure that their caregivers are attentive and safe. Most of our supports really should be for the caregivers, not for the child. That's also really clear in research. And before I got here, a lot of our services, and I oversee all of our services, a lot of our services were one-on-one stuff with kids. I challenge you, go do some research. Find the study that says one-on-one therapy with 8-year-olds gets you to a very good outcome. What you find instead in research is that the interventions that work, the ones that are evidence-based, they involve caregivers. They involve the people who are taking care of that child. So all that we do needs to be involving caregivers. If you have a kid that you're working with that's in foster care or in adoptive home, make sure that caregiver is involved in supportive services so they understand how to take care of that kid, keep that child safe, minimize additional trauma for that child, and help them function better. With 1 minute left, any other questions? I wish this could have been in person. It's hard to have these conversations looking at myself on the screen here, but I hope this was helpful. I hope it helped explain why this is so important to the department. And it's not just Indiana. We've been doing this since before the feds wanted us to, but it lines up with what the feds are doing as well. Again, that Family First Prevention Services Act, FFPSA for short, is all about this. It's all about using services to keep families safely together because that's what's best for kids.